Hello there.
Hello.
Would you mind? Hello there.
Hello.
Would you mind if I examined your heart?
Yes.
I'm going to start with. Hello there.
Hello.
Would you mind if I examined your heart?
Yes.
I'm going to start with your hands and then move to your chest.
Okay.
All right? Okay. Good. Have you got any pain in your shoulder at all?
No.
I'm going to lift your arm up. That's great. I'm just going to pull the blanket down. Okay, rest your head back. Okay, I'm just going to press on your chest, yeah? Pressing your chest on the other side. Okay, I'll ask you to sit forward for me. Breathe in, stop there. Breathe out, stop there. Breathe away. Just pressing on the side of your neck there. Good. Deep breaths in and out through your mouth. And out. Okay, now lie back for me. Just look towards the wall for me and rest your head back on the pillow. That's great. I'm just going to examine your tummy now, if that's all right. Any pain in your tummy at all?
No.
Okay, rest your head back. Breathe in and out. In again and out. Okay, breathe normally. Okay, same again. Breathe in and out. Breathe in and out. Okay. Okay, that's fine. Thank you. This young lady, who's comfortable at rest, appears to have dextrocardia, as evidenced by her apex beat, which is in the right fifth intercostal space in the mid-clavicular line. Her heart sounds themselves are normal, and there is no evidence of cardiac decompensation. Her liver dullness appears to be on the left rather than the right, which would support a diagnosis of situs inversus rather than dextrocardia alone. Furthermore, on examination of her lung fields, she's got coarse crepitations at both lung bases, which may be consistent with a diagnosis of bronchiectasis, which can complicate Kartagner syndrome. In summary, this lady has dextrocardia and situs inversus in combination with bronchiectasis. Bronchiectasis may imply that she has immotile cilia, which would be part of the Kartagner syndrome, which comprises situs inversus, immotile cilia, and sinusitis. I would like to take a fuller history to ascertain whether she fulfills all these criteria. Dextrocardia is a common trap in MRCP type examinations, and the important thing to note early on is that the apex is poorly felt or not felt at all in its usual left-sided position, and that the heart sounds are absent. They may be dull, and in some patients heart sounds can indeed be heard in the whole chest, which could lead you to make an incorrect diagnosis. As soon as you've established that the cardiac apex is in fact on the right side, you need to complete your usual cardiological examination, listening to each of the valve areas in turn, assessing the heart for valve pathology, evidence of decompensation. But you also need to move on to assess whether this is dextrocardia in isolation or whether it's dextrocardia as part of situs inversus, where all your viscera are in a mirror image configuration. So in these situations, it's important to find and to demonstrate that you're looking for evidence of a left-sided liver. Unless there's hepatomegaly, this will usually be by demonstrating dullness to percussion in the left upper quadrant. We should also then go on to look for evidence of immotile cilia, and bronchiectasis is one such feature which this patient had. Kartagner syndrome describes the triad of immotile cilia and all its ramifications, plus situs inversus, and evidence of sinus pathology, so dysplasia, recurrent sinus infections, and so on. The immotile cilia themselves can cause respiratory pathology such as bronchiectasis, and can also in males be associated with reduced fertility, and to a certain extent in females as well. It is important to make this diagnosis, as it has multi-system ramifications. Dextroversion refers to pure dextrocardia without any malplacement of the other internal viscera. And isolated dextrocardia tends to be associated with more congenital cardiac abnormalities than situs inversus. As in this lady, complete situs inversus is often associated with a structurally normal heart.